Hi, Isacos friends. Welcome in the Isacos world. Being a chair with Danny Lee of the Shoulder Committee, I am so proud to introduce this excellent webinar on calf repair and transfer with many friends. So I wanted to thank all the friends that are taking care of the Shoulder Committee. I want to thank also the Isacos team to organize this excellent webinar. Welcome in the Isacos world, and I give the word to my friend Danny.
Hello everyone, and greetings to all those who are joining us from around the world. I am Danny, together with Giovanni. We're the current chair of the Isacos Shoulder Committee. And this evening, we're most privileged to present to you this webinar on massive calf tear, and we're most privileged to work with UPCAS. So we present to you an international panel of speakers and some of the best speakers in the Asia-Pacific region. So let's get going, and I hand you over to the moderators, Giuseppe and Bancha. Thank you, guys.
Thank you, Danny and Giovanni. Welcome everybody to this webinar on the massive irreparable rotator cuff tear, together with my co-chair, Bancha Chernchoy, on behalf of UPCAS and Isacos. We present an interesting panel of international speakers. My co-chair, Bancha, is going to present first speaker now.
Thank you so much. So we're talking today about the massive rotator cuff tear. So we have international speakers. This is a very good opportunity to talk everything about the rotator cuff. Okay, so let's start the first talk. Okay, so the first speaker will be Dr. Milano. You're talking about defining the problem of massive irreparable rotator cuff tear when it's too late for repair and too early for the metal. Okay, the stage is yours, Milano.
Thank you, Bancha. This is my talk to introduce the topic of today and to define the problem massive irreparable tears. This is my disclosure. So when we talk about massive irreparable tears and treatment options, we have to consider this large window, therapeutic window, where most of our patients are in a sort of gray zone, where they are have a lesion that it's too late to be repaired, but they have no indication for a replacement with a reverse shoulder arthroplasty. So when a rotator cuff is considered irreparable, basically when we have no chances for repairability, for tendon healing that cannot be predicted after surgery, and we have no chances for functional recovery after surgery. So let's look at these three different issues. Repairability. We know that arthroscopically repairable rotator cuff tears ranges between 6 to 30% of our cases. For sure, tear size can be assessed on MRI and the preoperative imaging, but unfortunately, you cannot decide before surgery if a rotator cuff is repairable or not. Besides a technical issue, there is a biologic issue that should be considered that is related to the chances for tendon healing. We know that large and massive rotator cuff tears have a very high risk of recurrence or non-healing, up to 94% as reported in the literature, and the most relevant outcome predictors are related to the age and the tear size. And according to some severity index scores like these published by one, if we have a score exceeding 4 points, we have more than 50% of chances of non-healing or repair. That is quite unacceptable from a clinical standpoint. Regarding functional recovery, so-called pseudoparalysis can be defined according to different aspects. One is for sure functional. aspect that is related to combination of different isolated loss of motion. So when we have a more than one deficit in active elevation or external rotation or internal rotation, we have a true pseudo paralysis, and sometimes it cannot be changed after surgery. Regarding the tear pattern related to pseudo paralysis, Philippe Collen and Alex Lederman defined this spectrum of disease that is related to the combination again of more than one tendon at least two planes. So anterior superior or posterior superior complete tears are related to pseudo paralysis. But what is really the game changer is the subscapularis, because when we have more than 50% of tear with the fat infiltration exceeding grade 2 according to Guttalier-Fuchs, we have a chance for a pseudo paralysis. And most of the times, this is a high risk of unsuccessful surgery for rotator cuff repair. But when this patient is not an ideal candidate for a reverse shoulder arthroplasty, when he's still young and is a high demand patient, when has an early to mild degenerative disease, so AMADA classification stage 1 to 2, when has a stable fulcrum kinematic, so it's still able to have a good function, and when alternative to surgery show to be effective somehow. So according to some algorithms, there are different options that we can consider, most of them called joint preserving surgeries that collect the different options, as Philippe Valenti showed some years ago, ranging from simple debridement to complex tendon transfers. Unfortunately, when we look at the literature, there are some overlapping indications and inconsistent results. So the goal of our speakers, of our panel today, is to try to bring some order to this very challenging issue. So I'll leave now the chance to our speakers to show their points of view. Thank you.
Thank you so much, Milano. Okay, so you have any voting after this? No. So
Okay.
So if not, we can go to the next presentation.
Okay, the next presentation, it's my pleasure to introduce my co-chair, Bancha Chernchwit, and his talk is on fixation of massively repairable rotator cuff tears. Don't overstate, it's irreparable.
Thank you so much, Milano. So I'm talking about the massive irreparable rotator cuff tear, repairing the irreparable. So don't overestimate or over treatment. I can move to my slide. Yes. Okay. Good. So so sometimes we are doing too many reverse. I saw many patients. So if you look at the definition of the massive cuff, it can be from the big size tear like 5 centimeters or more than 2 tendon tear, okay, complete, or the exposure of the tuberosity more than 2/3. This is the definition. So if you look at the clinical repairable criteria composed of 4 things. First, the clinical, if the patient have not too bad, I mean no muscle atrophy, no pseudoparalysis, good center, mean the proximal migration is not too bad, the HI is more than 6, or good muscle quality, Guttalier 1 or 2, or the patient have like Pete 1 or 2. Most of the time, these are the repairable patients. So don't jump to do over treatment for this patient. The irreparable criteria, so composed of, so these are the irreparable criteria. If the patient have muscle atrophy or pseudoparalysis, proximal migration or no center, ASI less than 6, or severe muscle atrophy, no muscles like Guttaria 4, or no tendon, that's mean Pate 3. But sometimes the Pate 3 repairable, like in trauma patient, they have very bad retraction, but the tissue quality is good. That also can be repaired. So don't overestimate or over-treatment for this kind of patients. So two more factors that you need to consider is the patient factors and the surgeon factors. You need to discuss with the family about the plan of treatment, okay? Do they accept the failure? Because in massive cup tear, you can have like 30 to 50% of failure, okay? So let the family and the patient judge with you, give them the pros and cons. So the key concept of the repair is a tension-free and maximum footprint coverage. You need to make it tension-free before the repair. Don't jump to do the repair before the release. Okay, so especially the anterior cuff, you need to make a very nice superior release the interval. Don't resect the comma tissue because it's connecting to the subscapularis and supraspinatus. And the anti-release, okay, after the superior release, then we go to the anti-release. Release coracohumeral ligament, expose the coracoid process, base of coracoid, conjoint tendon. For the anti-release, sometimes you must be very careful because you can see the musculocutaneous nerve and also the axillary nerve in the front, okay? So go very slow. And also you need to release MGSL, IGSL, okay, and also the capsule. Sometimes patients have some stiffness, you need to do manipulation before the repair. Not many knots and not many holes because you can strangulate the rotator cuff, reduce the blood supply, and can be cause of the type 2 tear. So we publish the technique we call blended suture bridge technique. We make less hole in the cuff, okay, and we have more gap between the holes. So this can lessen and decrease the chance of type 2 tear after the surgery. So let's see the first patient. She is 58 years old. So she had massive tear from trauma, 6 weeks. She went to see two doctors. Two doctors said you need reverse because you have really bad rotator cuff. But if you look carefully at the muscle quality, AHI is good. So this patient, I think she's just 58. I give her the chance. So when we get in after we do a good release, okay, do microfractures, then we can see that the patient have very good cup mobilities and you can reduce the cup back, okay, and you can repair the cup nicely, okay. So after the surgery, the patient doing very well and she had a good function after the surgery. And this is an MRI after the surgery, okay, the patient quite happy. So the second patient, she's 70 years old. She's very active, okay. She has a pseudoparalysis, but you look at the x-ray, there's no proximal migration. Even the patient has severe tear of the subscapularis and supraspinatus, but the muscle quality is good. If you look at the criteria of repairable, so the patient still have good AHI and good Guttaria. So this patient, even she is 70 years old. So after we make a good release, she have very good cup quality and she has no osteoporosis, okay? So I slow release, I keep the comma tissues, expose the coracoid process, okay? And after that, we can fix her rotator cuff back, okay, nicely, yeah. So, and she had, this is subscap repair and the supraspinatus repair. So this is, we also do the biceps tendinosis for her. Yeah, she's very active. And after surgery, the patient have very good outcome. And also MRI show really nice healing of supraspinatus and subscapularis. So don't overestimate. Even she's 70, but she's active, right? She can give the chance. So in conclusion, don't overestimate the irreparability. So always concern 3 factors: cup factors, patient factors, and surgeon factors. And always discuss with the patient family, okay, about the plan of treatment and let the patient and the family judge what is a treatment option for them. Okay, thank you so much. Okay, thank you.
Thank you, Bancha. Excellent talk. So this is the question: what would be your management choice for this patient? 71% voted for cuff repair.
Thank you.
Any questions from the panel? I have just a quick question for you, Bansha,
Yeah.
regarding the so-called interval slides. So the posterior interval slide that
Yeah.
some years ago was so successful, so popular, but in the last years, there's some decline in popularity, you know.
Yeah. So the concept of cup repair is that you should not separate the cup from each other because the cup is like a patch. So you should connect supraspinatus to infraspinatus. Don't slide it. And also supra and subscap, you also connect it with the comma tissue. Okay. Don't resect it. So this is a concept of cup repair. You need to have very good release and don't resect. Don't make interval slide anymore. Okay. Milano.
Okay, thank you. So it's your turn to introduce the next speaker, Bansha.
Yeah, the next speaker will be talking about the real superior capsular reconstruction with fasciolateral autograft for irreparable rotator cuff tear, strategies for excellent clinical outcome. My good friends, Teru Mihata from Japan. Teru, the stage is yours.
Thank you, Bancher. So please show my slide. By myself?
Yeah.
Where?
Teru, you can move left and
Does
right.
not work actually. So it
Okay. The remote control will share in 1 second. Yes, it's coming. Very good.
okay.
It's coming.
Okay, thank you. I'm Taro Mehara. My talk real issue using autograph fasciolata.
Teru, click the right.
Does not work?
Yeah, it's coming.
Oh. Okay, here's my disclosure. And irreparable tear patient has a big defect on superior side. That's why during abduction, human head shifted superiorly and hit acromion and suffer impingement pain. And also center of rotation of human head displays superiorly, which prevents the normal abduction. For this kind of irreparable cuff tear patient, we developed supercuff reconstruction using autograft fasciolata. This surgery graft attached medial to the supragranule, laterally to great tuberosity, and then graft depressed the femur head down and also restore center of rotation. That's why using the deltoid muscle, patient can elevate arm after surgery. So how SCR will improve shoulder biomechanical factors without local repair? After SCR, graft tension in medial lateral direction and anteposterior direction improves shoulder stability. That is a tension effect. And also thick graft improves the shoulder stability. It's a spacer effect. And also increase tension of subscapularis and infraspinatus muscles, restore force couple. To achieve these biomechanical benefits, the biomechanical characteristics and healing of the graft are key. This is ideal graft for SCR. Fasciolata autograft, stiff graft, 6 to 8 mm thickness, and optimal anteroposterior and mediolateral dimensions. Why fasciolata autograft? The history of SCR already shows that this answer. I started the SCR in 2007. Afterwards, United States, European country, Asian country, South Africa, Australia, Latin America, anywhere started SCR. But recently in the United States, the popularity of SCR is declining because their SCR is not real. But other areas, especially Asian country, SCR is still growing because this is a real SCR. So how does our SCR differ from American SCR? The difference between our SCR and the American SCR is only the graft used. So surgical technique and surgeon skill are same, but similar, but only the graft different. Our SCR is fasciolata autograft, but American SCR dermal allograft. Fasciolata, of course, very thick and stiff, but dermal allograft very elastic and thin. So that's why American SCR cannot restore the stability completely. That's why the the high rate of graft tear after surgery. So fascial autograft is highly recommended for SCR to get excellent clinical outcome. So recently, even in United States, some surgeons started to use fascial autograft for SCR. Then they can get very nice, excellent clinical outcome after surgery. So even in United States, if they started to use the fascial autograft, they can get good outcome like our result. And also, we already published the clinical outcome after surgery, 10 years after surgery. This is the result. Graft survival rate 10 years after surgery, they are 89%. And also, this is the active shoulder elevation after SCR. 1 year after surgery, significantly increased from 89 to 149. But 1 year after surgery, it's not final outcome, still increasing. Then 5 years, 162, and 5 years and 10 years, no changing. So these patients, all patients, 10 years after surgery, maybe you cannot realize which side I did surgery because actually the patient also, they forget which side they did surgery because they feel normal. Another benefit of the SCR is the high rate of return to sport. This is a variable player. Before surgery, pseudoparalysis and with the massive tear. Then we did the real SCR using autofacciata. Then 1 year after surgery, graft healing very well and good elevation and good external rotation. And she returned to the sport variable, and 7 years after surgery, still active. I always telling the graft must be thick and stiff for SCR to get good outcome. But how we can make stiff and thick graft? I recommend to use the intermuscular septum to make a thick graft. I'm showing the movie file. On the surface of fasciata, this fasciata, on the surface fasciata, you can see the intermuscular septum, which is attached to the femur bone. We separated this is a two tendon tissue usually. Then sandwich, then suturing outside, and the multiple mattress suturing in the middle is very important to make a stiff graft. But some patients, they are very thin fasciata, so it's not easy to make a thick graft. But I want to make a thick and stiff and strong fasciata graft. So how we can make these grafts consistently? We developed the suture patch. It's a polyester patch. We usually sandwich the suture patch like this. Then we can make a thick and stiff graft very easily. So like this, the sandwich, then suturing. Then after surgery, this is a cadaver using the suture patch with the very thin fasciata, but very stable. So this guy tried to push the humeral head to the acromion, but does not hit at all after SCR. We studied the SCR using fasciata and suture patch 2 years ago. Then graft tear rate so far 2% only. Actually, the decrease the graft tear rate. So if you use the suture patch for SCR, maybe you can get better outcome. So we really recommend to use it. So finally, we founded the International SCR Association, then to share our knowledge and surgical technique for real SCR and to educate young surgeons. And we finally did their first meeting in Sonoma this February. It was very successful. So if you want to join us, please contact us. Thank you very much.
Thank you so much, Teru. Okay, Mirano, can you introduce the next speaker?
Yes, now it's Pablo Narbona from Argentina, who is going to talk to alternative solutions for superior capsule reconstructions. So not only fasciolata.
Any voting for Teru? Teru, you have a vote? Yeah, he has a vote. Okay, which comes the most common use SCR? Fasciolata, long head biceps, right? It's equal, 32 and 33. Interesting. Oh, 32 now.
So long head of biceps is probably more popular, Teru. Probably in Europe, that's true. This is different in Asia, I suppose.
Okay, just 4%. No, yeah.
Okay. Let's listen to South America. What they are doing actually in Argentina, Pablo.
Uh-huh.
Yeah, great. Thank you very much. I want to thank. Can I have the control, please?
Okay, it's coming.
Okay. First, I want to thank to the ISACO Shoulder Committee for inviting me to this webinar. I think it's very good activity and it's very interesting to spread out the massive calf repairable against the go to the reverse prosthesis directly without the repairable. It is very important the Bancha talk to understand when we have to repair and where is the limit.
Thank you.
I don't have the control of my presentation yet.
Yeah. It's coming soon.
Okay. Wait.
Oh, yeah, it's coming.
Okay.
Okay. Bravo, spread is yours.
Right there.
You can control it now. Yeah.
Thank you very much. So I want to thank the ISACO Shoulder Committee for inviting me to this webinar. So it's very slow system. Right there. I will talk about alternative solution for supracapsular reconstruction. This is my disclosure. I will present two different options as in scaffold and augmentation procedure. The first one is going to be in a supracapsular reconstruction with a knotless internal brace construction. And the second one is going to be a bio-SCR with the long head of the bicep augmentation as a local autograft. In Argentina in 2015 with Dr. Barkley, developed a supracapsular reconstruction with the internal brace construction to do the strongest construction at that time. At that time, we mixed the concept of the Dr. Mihara about a supracapsular reconstruction with the concept of Dr. McKay of internal brace from Scotland. So we developed the supracapsular reconstruction with the knotless internal brace construction. We create our prototype in 2015. We proposed at that time inverting mattress fixation with the fiber tail on the glenn side with two sweep lock knotless anchors. Then we do with two fiber tails, one anterior and one posterior, running from medial to lateral, under over and over under to create the internal brace, and modify a split brace technique for fixation on the humeral side. We test on the lab and we get 540 newtons of biomechanical testing. This is a case 64-year-old with a massive irreparable calf that compromised supra infraspinatus with a retraction type 4 and a Hamada 2 classification. So in this kind of patient, I will try to conserve the joint. This is our technique. First, we have the graft with a 10 centimeter incision over the proximal femur, and we harvest the fascial atlas asterochoas. We have a 10 centimeter by 3 or 4. We always close the defect. Then we are going to prepare the graft. We are going to do an inverting mattress with the tiger tape to fix on the glenn side. And then we are going to begin to do the internal brace construction with two fiber tape, one anterior and one posterior, running over and under over to create the internal brace. After we have the graft, we are going to go to the interarticular review. So on the interarticular review, first we are going to prepare the footprint on the humeral and on the glenoid sides. Then we are going to fix the glenoid. We are going to prepare the glenoid side with the drill holes to put the anchors. We are going to put the first anchor on the medial row. Then we are going to introduce the graft into the joint, pulling from the internal brace sutures to do the glenoid fixation. I will do the glenoid fixation with the 2 swivelers, one anterior and one posterior. After I do the glenoid fixation, I will do the humeral fixation with the modified speed brake technique with one fiber tape from the medial anchor of the reconstruction and one fiber tape of the internal brace. At the end, I will complete the SCR reconstruction with the side-to-side repair using the internal brace construction as a ripstop configuration to do side-to-side repair and to have a good stability of the graft and to have continuity on the repair with the remaining tissue to have a good vascularity. So this is the patient, the postoperative control. We can see that the patient recovered the pseudoparalysis, and we can see the integration of the graft on the superior glenoid and on the footprint of the humerus. If we see the red line, that's the area that our graft covered the humeral head and complete the repairable, doing a very good incorporation of the graft. Nowadays, we are using the suture parts that Teru show us and recommend us to take a really strongest graft of the fascia lata. The other technique I will present is the bio-SCR using the long head of the biceps as a local autograft. This is a great biological option to help us to restore the shoulder biomechanics. We already know that the bicep provides restraint in a large tear and improve the fulcrum in our reconstruction. This is a case, 60-year-old man with a re-tear of the rotator cuff that I did 4 years ago, and this patient have a shoulder dislocation and the cuff fails. First, I will remove all the suture and the remaining anchors. I will prepare the footprint on the humerus. Then I will pass the sutures, 2 sutures on the bicep, like a cinch sutures. So I'll pass the sutures, and then I prepare the medial row with 3 different anchors. The posterior one is going to be a swivel. The middle one is going to be a 6.5 FT anchor with double fiber wire, and the anterior anchor of the medial row is going to be another swivel to incorporate the biceps to our reconstruction. So at that time, we are going to do the anterior cable reconstruction with the biceps. I pass the sutures, and I began the configurations. I always do close the medial row with the double pulley technique and complete the lateral row with 2 swivel to complete the repair. That's my view of the repair. And if we look at intra-articulary, we can see the incorporation of the bicep to the repair to do the anterior cable reconstruction. That's the postoperative control that the patient, after 6 months, recovered the pseudoparalysis and have a good function. And the MRI control, where we can see the incorporation of the biceps into the repair to improve the tissue quality of the cuff after the repair. So in conclusion, the augmentation procedure, we had to realize that the bio-SCR augmentation of the long head of the bicep produces less donor side mobility, but I recommend when we have a repairable cuff with a poor quality tissue. But if we are going to don't have a very good cuff to repair, I strongly recommend the supracapsular reconstruction to provide stable fulcrums, optimized for scapulars, and pain relief with a low complication rate. In conclusion, I think the augmentation procedure should be a gold standard for joint preservation in patients with massive cuff tears with no arthritis. Thank you.
Thank you so much, Pablo. You have any voting question?
Pablo,
to
I
see-
wanted to ask.
Yeah.
Oh, sorry.
Yeah.
Oh,
Yeah.
sorry. Go, Gus.
I just wanted to ask, when he does his long head of the biceps augmentation, does he do a formal tenodesis, or do you just leave it and see? And have you had any complications of that post-operatively with the biceps? Not with the rotator cuff repair, but with the biceps and anterior shoulder pain.
Yeah, I usually do both at the same time. I will call like an augmentadesis. With the same anchor, I fix to do the augmentation of the bicep and at the same time the tenodesis. I don't have any problem with anterior shoulder pain after do that procedure. So I don't need to separate the augmentation fixation and the bicep tenodesis fixation.
And you do
Or at the same
the
time
same
over
anchor,
the
so you
top.
leave it intact. You just,
Yeah.
you don't have to cut it.
Yeah, because I really believe that if we stop the movement of the bicep, it's not going to be necessary to fix in another part.
Great, great, thank you.
Great,
You're
thank
Thank you, Pablo. Do we have results of live voting?
Yeah.
Great.
Okay. Milano? No.
Yes, we're waiting for the live voting. Okay, so which of the
Mhm.
following factors do you use to decide
This-
whether on how to augment? All the above are important factors.
Okay.
And
All of the above.
the second one is the contraindications. Active infection, stiffness, young patient,
Mhm,
osteoarthritis,
mhm.
and ASC are correct. Interesting. No, young patient. Nobody voted young patients.
That's very interesting. I think
So
this procedure should be the best option for a young patient with massive calf and
Yeah.
try to avoid the shoulder replacement.
so patients with still high demand.
Yeah. I
Okay.
still do it in sportman and in very young patient, 45, 50 years old, and I allowed to do sport after the SCR procedure. That Terry show us to the long-term result about that, and I think it's possible to go back to sport.
Pablo, any overlapped indication with the
Rotator cuff repair because of the extent of the cuff muscle and tendon damage and other patient-related factors, which can include many things as we learned about from Professor Milano's talk. Kind of the algorithmic approach that my partner Bassem El-Hassan has really adopted with Sanchez Sotelo was really this kind of group with a massive posterior superior repair where we think that a lower trapezius tendon transfer can be able to restore people back to a better function. Key points of muscle tendon transfers around the shoulder. Really, you want to ensure that transferred muscle is expendable, that the muscle tendon unit has similar excursion, that the line of pull is transferred to the recipient muscle are similar, and the transferred muscle should replace at least one grade of strength of the deficient recipient muscle. And as you can see the latissimus dorsi is at a different angle, and that's why my partner Bassem El-Hassan has really adopted the lower trapezius tendon transfer because of that angle. I've adopted it really. We published an article back in 2019 where we had about a 40% clinical failure rate with our latissimus dorsi transfers. Dr. Warner then also came in 2001 finding similar late rupture of about 44%. So the lat dorsi transfer in my hands was not as successful as I had wanted it to be. So in the setting of these irreparable posterior superior rotator cuff tears, biomechanically, we showed that the lower trapezius transfer is anatomically positioned better to restore the muscle force couple compared with to the latissimus dorsi transfer. Really, there's been excellent clinical results with this arthroscopically assisted lower trapezius tendon transfer, published mainly by Bassem El-Hassan, my partner, really looking at improvement in abduction and external rotation strength, or the ability to put your arm into space. We also compared it to the superior capsular reconstruction, where really there were similar outcomes. However, the transfer did seem to have some better function when we put the arm into abduction and external rotation. So this is really his technique that he's perfected and taught to us, and I thought I would go through a little bit of that for our audience. So really the draping, you want to make sure that you have at least 2 centimeters medial to the medial border of the scapula. You want to kind of abduct and forward elevate the arm. That gives you more exposure to the scapula. We use an IO band to just hold those drapes so they don't come back in our way. The marking for the approach, I think, is really important. This is something that he's gone. So we'll find the medial border and the spine of the scapula. We'll then mark or measure 5 centimeters from the medial border and draw a perpendicular line down. Then we bisect that line. That really is kind of where that lower trapezius tendon transfer is. Then we'll find the soft spot, and we'll put our thumb right at the medial border and inferior aspect. There's a soft spot that you can feel at that scapula. This seems like a little silly thing, but it really helps orientate you on your incision, where we'll then place a line at that area and you can see where that incision goes. And this really aligns you in a better anatomical position. When you get down there, we'll make the incision. We take the scalpel blade and throw that off the field to remove or prevent any C. acnes. We place a gram of vancomycin powder in, but you'll see a significant amount of fat that's over that area. When you first try this yourself, it's a little bit intimidating as you kind of go through, but as you get a better sense of that anatomy there, you'll see. So that fat has to be removed before you start looking for that lower trapezius tendon. Once we find that tendon, we go up and make sure that it's attached onto the superior or scapular spine. We'll then take sutures to try to imbricate some of that tendon tissue so it's relatively thin, and that's how we can keep it in line for when we do the rest of the procedure. We then prepare the Achilles tendon allograft on the back table. You want with the suture starting out to in so that it'll lie flat when you get it onto the greater tuberosity. We want to end the suture from inferior to superior so it lies flat. And we color the medial side of that graft so that we can orientate ourselves in case it flips over arthroscopically when we bring it into the shoulder. It makes it a little easier to try to orientate yourself. Then you want to find the edge of the deltoid by removing some of that infraspinatus fascia to make graft passage easy. You want to make sure that you're below the deltoid but above the infraspinatus. That sounds very obvious, but in that area, if you don't dissect and take your time here, sometimes you can go through it. Then arthroscopically, we'll place our first medial anchor through Nevisor's portal. We line that up with the spinal needle, as you can see, and then we'll place our swivel lock anchor in there. It's easier to do because we'll keep that out through Nevisor's portal. It's out of our way, and then we can bring that over the top when we finish our repair. Then in these videos, you can see that we'll come from anterior, grab our sutures of our Achilles, and then pull that in, going under the deltoid but over the infraspinatus, and we'll cycle that to make sure that we're absolutely not caught up on any other soft tissues. Then as we go, we'll place our first anchor, which is another swivel lock. We try to make that as anterior and at the articular margin as we can. We then place our anterior anchor, and then we'll place our posterior anchor, solidifying the graft in place, and then bring that medial anchor over the top just to secure. Then we'll go to the back. We'll place the arm into abduction external rotation, and we'll do a pulver tap weave of our Achilles tendon through the lower trapezius tendon that we had already marked. We will then suture the excess graft over the weave and close the gap medially. We want to make this as tight as we possibly can. Because there's a certain amount of stretching that'll happen, that's why we have them in maximum external rotation abduction, and we really try to crank this as tight as possible. We then place them in a gunslinger orthosis and external rotation and abduction for 8 weeks. No internal rotation. We want to prevent any internal rotation. Once we're past 8 weeks, we start active assisted range of motion. We delay strengthening till about 16 weeks, which is a little longer than we do for our rotator cuff repairs, and then back to full unrestricted work at around 6 months. In conclusion, really you want to concentrate, and I tried to make the videos so that you could see. I think one of the challenging parts is to find that lower trapezius tendon. Once you find that, then the rest of the procedure is fairly simple. You want to organize and have that medial anchor first because it can get very difficult as the Achilles tendon is thick. But overall, this has been very successful for us in our area with these younger patients with these massive posterior superior rotator cuff repairs. Thank you.
Thank you so much, Mr. Masoka. So look at the poll. In younger active patients with massive posterior superior cuff tear, preserve humeral cartilage intact, repair subscap and external rotation weakness. So the poll is partial repair and margin convergence, 38%. Lower trapezius transfer is 25%. And also tendon transfer only, 25%. SCR 13%. And reverse, how many percent? We cannot see.
Yeah, it's a zero. It's zero.
No percent. That's nice.
Okay, so it's time to go to the next speaker. We have a few minutes of discussion altogether at the end of the session, maybe. So the next live voting: in your current practice, what is your most common salvage option for a massive irreparable subscapularis tear? A, non-operative management; B, tendon transfer; C, anterior capsule reconstruction; D, reverse total shoulder arthroplasty, case dependent. E option. So next speaker, it's my pleasure to introduce my friend Jae-Choo Yo. His talk is on subscapularis massive irreparable tears, treatment options. Thank you, JC, for accepting our invitation to participate to this webinar.
Okay.
It's my great pleasure. Thank you for the invitation to the global perspective of massive irreparable cuff tears. It's a course with APCAS. My topic would be, what are the treatment options for irreparable subscap tears? I have nothing to disclose for this talk. If the subscap is deemed to be irreparable, there are many evidence that non-operative treatment may be effective in over 2/3 of the patient. Over 70 or maybe older with low demand, usually a massive subscap tear is combined with a supra, so I think reverse shoulder arthroplasty would be a good option. Other than reverse shoulder, what are the salvage options? But before I like to talk about salvage options, despite many subscap tear looks irreparable, Lafosse type 3 or 4, U type 4, acute and chronic, it's a big muscle and it can be repaired. These are some of the MRI that looks very large, but it was very well repaired arthroscopically. These are the MRIs that looked very bad anterior superior tear. They are all were repaired arthroscopically. However, there are some who cannot be repaired. What are the salvage options? As we know, tendon transfer, this is the subscap pathway. Pec major transfer, LD transfer, pec minor transfer, and maybe anterior capsular reconstruction have some role. If you look at the publications since 1997, you can see at the later stage of 2015, more papers are on LD, and there's a minimum pec major transfer papers. So I'll just talk about pec major and LD transfers, since pec minor and ACR is not much evidence. Only one or two authors report this. The time frame. Pec major transfer since 1997 in JBJS, they report with recurrent anterior glenohumeral subluxation with irreparable rupture of subscap muscle. Since then, it's almost 20 years have passed or more, and with the long-term follow-up by Christian Gerber and Philip Morodo team, they both report roughly around 30 patients or less with complication rate of 20% with much improvement of the CS score. However, their strength did not improve in 2/3 of the patients. There are two issues in pec major transfer, which is to go over or under and use which sternoclavicle head or both. To go over and under conjoined tendon, most of the literature says there's no difference in constant score complication rates. So I think maybe it would be easier to go over. Regarding which head, sternoclavicle, it seems that the sternal head transfer had a more graft failure, but overall there was no satisfaction. There was no score difference between the two heads or using the entire tendon. Latissimus dorsi transfer, as you know, this LD was favorized by Bassam al-Hassan, and you can see the publication is dramatically increased in this LD transfer because of the vector. You can see the LD has more close to approximate the native subscap regarding internal rotation. And however, LD transfer also show a reduction in adductive moment arms. And in the cadaver studies, it better restores the anterior posterior force couple and prevents superior and anterior humeral head submigration. What about the clinical scores? If you look at this multi-center study with 72 patients, pain VAS and a CS score, active flexion improved significantly. Surprisingly, they show that 30% showed a complete belly press test improved. However, we need more studies or longer follow-up with these clinical outcomes. Another study, 30 patients by our colleagues from Korea, showed a similar results, saying that the scores and range of motion significantly improved. However, you can see that the exam was in 2/3 of the patient eventually showed a decrease in the strength. These are my cases. If you look at 55-year-old with left shoulder pain, show a large subscap tear. We'll try to reduce arthroscopically, but failed. So we did a partial repair and LD transfer. And you can see at the post-op maintenance, at 4 years in phone survey, the patient showed a very good score with the range of motion 90%, but I have a constant heavy feeling of the shoulder and pain at terminal range. This is a 68-year-old right shoulder pain, a familiar anterior superior large tear with partial repair with the LD transfer. You can see the post-op, the tendon is well maintained, and at 4 years, score maintained with good, relatively maintaining the scores. But in summary, the treatment, it's mostly effective with non-operative treatment, reversed for elderly patient, and LD transfer is recent trend. You're welcome to APCAS at September 10 to 12, and you're welcome to the KSCS at next year, March 26 to 27 in Seoul or nearby. Thank you very much.
Jesse.
Thank you, Jesse.
And this is the vote. In your current practice, what is the most common salvage options for a massive irreparable subscapularis tear? Tendon transfer. Pec major latissimus dorsi, 39%. Non-operative option, 26. Anterior capsule reconstruction, 17%, and reverse 17%. Okay.
Okay. Thank you so much.
Any questions for our speaker? Okay, let's move to the next Bancha.
Yeah. So the last talk of today is about the practice, measure, improve live virtual reality rotator cuff repair with personalized analytics by Dr. Danny Goel. Okay. Danny, please. The stage is yours.
Thank you very much.
Hi,
thank
Danny.
you, Isakos and Apkos, for the opportunity. It's a pleasure to be part of this esteemed group of shoulder surgeons. So the thing that I'm going to talk about today is one thing that all the authors assume or all the speakers assume today, is that if you want to succeed with these cases, the one thing that has to happen is you have to be a master surgeon, not only from an anatomical perspective and understand the anatomy of the shoulder, but also from an arthroscopy perspective. And complex rotator cuff repair and the procedures that have been shown do require this level of expertise. So how do you get to become an expert when you're a resident fellow or only an early career surgeon? Because frankly, the exposure is variable. It's high stakes in the OR, and we get inconsistent practice. So when we think about a rotator cuff repair, and I'm going to show this video to you next, the complexity of arthroscopy is that you're trying to fix a rotator cuff repair by not looking directly at the anatomy, and you're looking at it through a scope, which is angled either at 30 or 70 degrees to the horizon. So the things that changes the curve is you need an opportunity to have unlimited repetition. You need to have an environment that allows you to recreate what you would actually do in the operating room. And we know that cadavers sometimes are limited because they're not positioned in beach chair lateral. You can't move the arm. And sometimes the humeral head sits inferior to the glenoid, depending on the cadaver status. So let me walk you through a video of what this would look like. So this phone app, you can download for free off the store. And what it allows you to do is you can ask this AI a question, say, I want to practice shoulder arthroscopy and to do a rotator cuff repair. So the thing that the AI will do is it'll give you access to videos, but then it'll launch you into a virtual reality application. And a virtual reality is where you wear an Oculus headset and you are put into a virtual environment where you're interacting with this virtual patient. And you can see I can put this needle where I want to, and it's giving me knowledge of things that the experts know well in advance when they put a needle in the back of the shoulder. So now here I am, I've got the scope in the shoulder, and I'm doing a diagnostic arthroscopy. Now what you'll notice here, and what the experts will tell you, is that to get the best view in the shoulder, you have to do one of four things. You can move the camera, you can move the scope, and you have to know when to move the arm. And so you can do all these things in this virtual environment to really understand the anatomy and where portals are. Now, we talked about complex rotator cuff repairs. One of the things that we assume is that a surgeon has mastery of the anatomy, because if you don't have mastery of what normal looks like, it's very hard to interpret what abnormal looks like. So again, how do we drive and accelerate the skill set of a learner in this environment by giving them an opportunity, as you can see in this case, to behave just like they would in the real world? And we can do really novel things in this environment, like turn the skin off. You can see the scope as you're looking at it here, and you can put anchors in just like you would in the real world, and I can shuttle sutures. What's novel about this approach is that every step that I take, every portal I use, where I put my anchor, even the angle of where I put my anchor, all that data is being measured for you when you come back and receive your personalized feedback. So in this case here, you can see I'm shuttling my sutures to the back of the shoulder. Again, and I can turn the skin off on this virtual patient whenever I want if I feel lost. Because again, the master surgeon already knows and thinks these things, but when you're learning how to do this, you have to find an environment that allows you to practice and fail at your own experience. So this is showing here putting a lateral anchor in. And again, if my lateral anchor is at a wrong ankle or angle or too low or too high, the system will measure that and provide that feedback after I'm done this case. So here I am watching with the anatomy off because I want to see where I'm putting that anchor relative to the anatomy looking directly at it. And here's some data just showing me how I did. And then I can pull the anatomy out of the virtual patient and see where an expert would have put their anchors. So now I go back to the iPhone and I can see exactly where I made mistakes, where I can get some coaching and where I can improve moving forward. So I'll move to the next slide here. I'll go back one. So as I was mentioning, every session is observed, measured, and scored automatically. So when you go into the system and you turn the skin off and on, it's actually making a measurement of your level of expertise. If you turn the skin off quite a few times, it knows that you're a novice learner. So the feedback you'll get will be guided towards that level of expertise that you've shown while you were in the virtual environment. So the feedback and the opportunity with this digital experience is really to go in and practice and get that expertise on both arthroscopy and the anatomy. Dr. Yu showed how you do a tendon transfer from the front. Dr. Mazaka showed how you do a tendon transfer from the back. Unless you have expertise in anatomy combined with arthroscopy expertise, those cases become extraordinarily hard. So to wrap up, some of these cases are low volume, but the stakes are very high. And we don't have access to practice globally. Some are from around the world. Some places don't have access to cadavers. So outside of learning during surgery, where else can you do unlimited repetition, make mistakes with no consequences, and get a real deep sense of anatomy? And this is where virtual reality plays a role. So as takeaways, 3 things to consider. We need to be able to practice this skill outside the operating room. Immersive VR allows you to practice that. And importantly, the feedback you get is personalized to the mistakes you've made in this digital experience. That leads to point 2, where the measurement that occurs is, again, personalized for your mistakes, and it gives you that objective feedback. And the end goal of this is to improve your level of expertise to the point where you could actually recreate what these experts are showing you, whether it's a biceps tenodesis, an autograft, an SCR, or a tendon transfer. Thank you very much.
Thank you so much, Danny. So, any question? Danny, you have any voting?
Danny, I have a question for you. Excellent talk, very, very interesting and stimulating topic. What about assessment, skill assessment of this practice?
Yeah, great question. And so the data that's being collected is a form of assessment. So we can tell in the system if someone is a beginner, a novice, an amateur, even an expert. And so the system is guided and measured when compared to an expert who's gone in and done a rotator cuff repair or a shoulder arthroscopy. This whole platform is set up for assessment.
Thank you. Thank you.
Thank you. So
I
have
had
some
a question,
questions.
Giuseppe. I
please.
had a question for Dr. Masoka. Do you really think that, do you really think that the indication procedure for an SCR or for latissimus lower trapezius transfer are different indication, or is about the same?
Yeah, I would say it depends on the, probably the comfort level of the surgeon. I think that the SCR, we, as Dr. Mahata presented, we use a thinner graft, here in the United States, and we didn't have as great of results because of that reason. And I think that the lower trapezius tendon transfer actually gives you kind of the thick graft that he talks about, and it's coming from a different area, so that can help really you're younger. The kind of the indication for me for that lower trapezius tendon transfer is like a laborer that needs to go back to, either construction or labor where they're lifting above shoulder level with external rotation strength, not just pain relief and being able to use their arm in space, but to able to provide force for that. That's really the person that I will do the lower trapezius tendon transfer on. Of course, you can bleed on either side of that, what you feel comfortable with, all arthroscopic SCR versus not. But I would say in my probably practice, that younger person with the massive tear that can't be fixed, I think that is the person. So Bacha had talked about the massive tear that's relatively acute, 6 to 8 weeks, big tear. We think we can fix it. I agree with that. This is somebody that's, a workers' comp in the United States where they've had a delay in treatment. Now they're coming to you at 3 to 4 months. There is some atrophy, and that's kind of when we'll put that in.
Yeah, thank you so much.
Right.
So a question for Jesse. Jesse, you are the front door doctor. So Jesse, what is your preferred graft choice for the massive subscap, the lower, the pec major, pec minor, or the LD? What is your preferred graft choice?
I think currently for so just to ration it out, the pec minor might be a little bit too small. Although Kotaro, our friend, says it's sufficient, but in pec major, I think with the longer follow-up, it works. But I think LD looks more reasonable in my hands. But as you know, we don't have longer follow-up, and the cases are very limited. So it's very difficult to say which is better. But I prefer LD, which is for me, it looks more reasonable. And but whatever we do, I think LD
You
or
use
PEC.
LD or LDTM? LD, just LD or LDTM?
I try to use just LD, but
just LD.
yeah,
Is
but
that too thin?
sometimes, well, it's not too thin. It's just sometimes the LD and TM, it's a little bit difficult to delineate. Sometimes it's easy. Sometimes it's just kind of blended in together. So in those cases, I just use both.
Yeah, but I saw the MRI, the healing, your tendon is a bit thin, Jesse.
Yeah.
Right? Yeah.
But the tendon is thin, but the rest of the muscle is very thick.
Okay.
I think.
Okay, good.
We have a few questions from the audience.
Yes.
First is about the muscle sliding technique.
Yeah.
This is a technique that was described first by De Beer in the 60s in Europe and was recently redescribed in India, Australia. So this is an Asia-Pacific issue. So friends from APCAS, you have experience of this technique, JC Bancha? Do you have experience with this muscle sliding?
I did not try yet.
I don't have experience. I'm just like a lot of surgery is just like kind of fashion. And 10 years ago in Japan, I saw this muscle advancement surgery done open. And then it just kind of wear down, or maybe only in Japan. And then now all of a sudden it's everywhere, especially in Korea. There's some key surgeons doing it. So we just have to wait and see how that works. I'm just against doing muscle advancement because most of the cases I can repair partially. And secondly, if we can't repair partially, I think maybe we're better off doing some tendon transfers or just patch augmentations. That would be my choice. And if they're older, I think reverse would be better than muscle advancement.
Yeah.
Okay, there is another question, the use of peroneus longus tendon autograft. Anyone has experience on the peroneus longus? Gus? Pablo?
No experience with peroneus longus. We use peroneus longus when we do AC joint reconstruction.
Yeah.
Yeah. Okay.
No, I don't have any experience with peroneus longus.
And another question is for you, Gus. How many Achilles tendon grafts healed successfully to humerus in your
Yeah,
experience, in your case series?
so yeah, and we've looked at a lot of this with, Dr. Ellison, Dr. Laura, Dr. O'Donnell, a lot of my partners. We do fairly many of them. And surprisingly, which makes no sense biologically, when, especially in, say, a failed, that's another thing, Pablo, I didn't say, like in a failed rotator cuff repair, we'll also try the lower trapezius tendon transfer before going to a reverse in, say, that middle-aged younger person. When the normal tendon doesn't heal, it's amazing to me that a cadaver Achilles tendon will heal. I'm not sure why I can explain that biologics, but it's still there. So it doesn't. So the question is, our percentage of those grafts on the greater tuberosity, when it fails or if it fails more at the muscle tendon, not necessarily at the Achilles greater tuberosity. So I would say really 90% of these heal at the greater tuberosity, which is very surprising to me, and I can't explain it.
Okay. There's a question for Dr. Teru. Teru, now you use a fiber patch, right? To make your graft thicker.
Oh,
So
yes,
how,
such a patch, yes.
how many millimeters you can make it thicker, and why you do that? Because your previous outcome is very good. How you can make it better? So
Yeah,
how many
thank you very much. Good
millimeters?
question. Yeah, actually the thickness only 2 millimeter, but yeah, 2 millimeter. But so but stiffness, it's dramatically improved. So stiffness of the graft is very important to make stability as the issue. So actually, yeah, before I started to use the suture patch, already the good outcome and the graft tear rate around 5%, but now 2%. So I'm getting better. And also not only me, actually the other doctor, yeah, especially young surgeon, some surgeons, the graft tear rate 10% or more. So those surgeons, maybe if they use the suture patch, maybe they can get a less graft tear rate and better outcome. So graft healing is key to success and to get good outcome. So
Yeah.
yeah, so that's why we use this. I recommend the suture patch.
I think I'm using suture patch, and I think it's very important to realize that the suture patch is the strongest, but also promote the scar tissue because of the configuration of the path. So here is my question for Terry. Why do you prefer to put in the middle like a sandwich or not over to promote the more integration of the cuff?
Oh, thank you very much. Yeah, so mostly the sandwich, but some patient the over. Then result is both is good. So you can attach the suture patch on top of the grass. So so doesn't matter where.
I think
So
it's very important that the suture patch give a really better structure of the graft. So to have better structure, more rigid graft, it's easy to get in and to accommodate the graft inside the subarachnoid space.
Yeah, that's true. Yes.
So if you put it on the top, any problem with the contact with the acromion that can make like
so I worry about that before I started to do that surgery, but actually I take MRI all the patient actually healing excellent, so no problem at all.
Yeah, nice.
So thank you everybody for this very stimulating discussion. Thanks to the participants, thanks to APCAS, of course. Pancha, you want to conclude? And
okay, so this is a very good opportunities and activities between ISACOS and APCAS. So thank you all the speaker from everywhere around the world. Okay, I think the audience can get some idea and knowledge about the massive irreparable rotator cuff tear options. Okay, Thank you so much, everyone. Thank you, Milano, and also thank you, Cassie, okay, for organizing this course. Okay. Okay.
Thanks, Swingleta, for this great organization.
Thank you
Thank you,
very
everyone.
much. Great.
Thank you,
Very
everyone.
good meeting.
Everyone.
Thank you very
Okay.
Have a good
Have a
day.
good day.
Thank
Bye-bye.
you. Bye-bye.
Day.
See you.